of you. At the outset, I would like to thank Kumaravel sir and the organizing committee for giving me this opportunity to speak in front of this august audience. It is really an honor, I consider, because I am a proud alumnus of Madurai Medical College. I did MD Medicine here. So my talk is on Prolactin unplugged beyond galactorrhea. So I've divided into two parts. So one is the clinical aspect. So beyond galactorrhea, can Prolactin do something clinically? And the second part is the newer concepts about prolactin action. So the first part, I will show you few cases. So case one is a 28-year-old lady who has come to us with oligomenorrhea and infertility. And on examination, she has expressive galactorrhea. There's no history of any drug intake. And we found that her prolactin was about 98 and her thyroid function is all normal. Her MRI pituitary is showing a 7 mm pituitary microadenoma. So what is prolactinoma, hyperprolactinemia? So the definition really depends on what sort of assay you use and what are the normative values for that assay. But in general, a prolactin level of more than 25 is considered as hyperprolactinemia. It is generally the levels are higher in women than men. And the sample for serum prolactin, they say, can be taken at any time of the day, although there is a circadian rhythm even for prolactin. Generally, we tend to take it in the morning because the levels are lowest then. And dynamic testing with TRH stimulation and all is not superior. But what we need to understand is whenever we test for prolactin, we need to avoid venipuncture stress. Any history of breast stimulation has to be asked for, and even strenuous exercise, because all of these can lead to an increase in the prolactin levels. So this patient, classically a microadenoma, a microprolactinoma. So second case is a 29-year-old software engineer, married for 4 years. In fact, he came to us with erectile dysfunction, infertility. The issue was in fact with the family because the wife had applied for a divorce saying this person is impotent. So there was a lot of family issues going on, and he had consulted an andrologist outside. And the first test done here was a serum testosterone, which was found to be low. And without further investigation, this patient was started on testosterone, and there is no improvement in the symptoms. So on further evaluation, so that is what Sriram sir was telling us, hypogonadism in men, especially hypogonadotropic hypogonadism in men. Look at the prolactin levels, because here this prolactin level was quite high, 320. Thyroid function was normal. His LH and FSH was low for the level of testosterone, and serum cortisol was normal. So this patient had a pituitary macroadenoma. This was a macroprolactinoma causing hypogonadism and the erectile dysfunction. So this is the presentation that we see in males with prolactinoma. So this patient was started on cabergoline. There was a response in the form of a reduction in prolactin levels and a reduction in the size of the lesion. Sperm count improved. We had to counsel the wife that there was an organic cause for this, and finally the wife conceived. So the third case is a 40-year-old female with galactorrhea since 2 months. She's been having a history of low backache for which she was on few medications. Her prolactin levels were elevated. It's about 55. Now we asked her to bring all the medication details, and that had NSAIDs, pantoprazole plus levosulpiride. Now there are multiple case reports showing association of an increase in the prolactin levels with levosulpiride, sometimes to the extent of even more than 200. So in this patient, levosulpiride was stopped. She is symptomatically better, and a repeat prolactin after 2 weeks showed a normal value. And drug-induced, generally keep in mind that usually it is less than 200. Certain drugs like risperidone, levosulpiride can cause an increase more than 200 as well. So you need to stop the drug and look for a reduction in the prolactin value. Usually we do it, guidelines say after 3 days of stopping the drug, you repeat the prolactin, but generally to be on the safer side, you stop it for a week and repeat. So the whole list of causes of drug-induced hyperprolactinemia, but the most common that we see will be all these antacids, domperidone containing antacids. So this is the commonest one that we see. So drug-induced, they may be asymptomatic, they can develop galactorrhea, amenorrhea, men can have low libido, erectile dysfunction, and there's also an increased risk of bone loss in women with antipsychotic induced hyperprolactinemia. So it's not really benign. So prolactin levels can range from 25 to 100. You need to stop the drug for 3 days and repeat the serum prolactin and consider use of alternate medications. So this is about drug-induced hyperprolactinemia. We look at the fourth case, a 26-year-old female planning pregnancy. She has regular menstrual cycles, no galactorrhea, not on any medications, and incidentally, she was found to have a high prolactin value of 65. Her pituitary MRI is normal. So what is the possibility here? So first is she's planning pregnancy with a mildly elevated prolactin, rule out pregnancy. So that will be the first thing. So look at the urine pregnancy test. The other concept, the case I am showing is to introduce a concept of macroprolactin. So macroprolactin is nothing but prolactin which is attached to IgG. So about 40% can have macroprolactinemia. So this really does not require any treatment, but it can be detected by the assays and it may show a spuriously high value of prolactin, leading to further unnecessary investigations. So the best way, if you are suspecting macroprolactin, is to do a polyethylene glycol precipitation and look at that sample, and then the macroprolactin is precipitated there and you will get a true value of the prolactin. So case 5 was a 65-year-old man who was brought to medical attention with history of headache and vision problems. His MRI is showing a 4 centimeter mass, it is locally invasive. His prolactin level is not too high, it's about 72. Other hormonal assays are normal. So in this condition, you look at this large adenoma there. So in this condition, you will need to remember that prolactin levels usually correlate with the size of the lesion. And when you do not have a correlation, when you have such a large adenoma, you're expecting about 250 or 300 or sometimes in thousands. When you do not have that, you have to think about the hook effect. So what is a hook effect? So you see here, this is the assay. Look at the top line. So you have the immobilized anti-PRL antibody which is attached to the test tube surface. You're going to add the antigen, that is a serum which contains prolactin, and then there is a signal antibody which is being added again. So what happens, there is a sandwich formation, and depending on the amount of prolactin, you will get a signal when the sandwich is formed. When you have too much prolactin in the blood, this sandwich is not formed. So some of the prolactin gets attached to the immobilized anti-prolactin antibody, some attached to the signal antibody. So your signal level will not be much, even though you're having a very high prolactin levels in the blood. So this is the hook effect. You just dilute the sample, 1:100 dilution, and you will get a value. The sixth case is a 48-year-old woman with amenorrhea and headache. She denies galactorrhea, but she has visual field defects. Her serum prolactin is around 94. So other hormones are showing suggestive of hypopituitarism, a low serum cortisol, T4, T3 low, and TSH is also low. An MRI is showing a pituitary macroadenoma. She's been started on dopamine agonist, and the prolactin came down to 5, but still she has headache, she has amenorrhea. And MRI brain, again, there is no reduction in size. So this is the concept of the stalk effect. Now patients with macroadenoma can have pressure on the pituitary stalk. So the pituitary stalk has got the dopamine which is coming in, and the dopamine is going to inhibit the pituitary lactotrophs from secreting prolactin. When there is a compression on the stalk because of the macroadenoma, this inhibitory influence is lost, and then you may have a slightly elevated prolactin. So this does not mean that this is a prolactinoma. So she underwent surgery and it was found to be a gonadotropadenoma. So this is the last case, a 22-year-old lady presented with oligomenorrhea, a BMI of about 26. She did not have any hirsutism or galactorrhea. Her prolactin was about 50, which is elevated, TSH of 5.2, and ultrasound was showing bilateral polycystic ovaries, ovarian volume of about 12, and no dominant follicle. So this patient has irregular cycles, and you have imaging evidence, so probably PCOS. Remember that PCOS, again, there can be mild hyperprolactinemia. Prolactin receptors are present in the adrenal cortex. There can be an elevation of DHEAS. There can be a mild elevation of testosterone. There can be hirsutism. So that is one reason why you have to rule out hyperprolactinemia or a prolactin-induced elevation when you make a diagnosis of PCOS, because PCOS is a diagnosis of exclusion. So from all these cases, what I want to say from the clinical point of view is that prolactin plus galactorrhea does not always mean a prolactinoma. So you may have an increase in the prolactin, you may not have galactorrhea, you may have other symptoms. You may have symptoms of hypogonadism, erectile dysfunction, decrease in the libido. You may have irregular menstrual cycles, fertility issues, vision problems. So all of these are a myriad of symptoms that you can see with an increase in the prolactin. On the other hand, you may have galactorrhea, you may have increased prolactin, you may not have a prolactinoma. It could still be just a drug-induced cause. So there are multiple reasons, and you need to keep clinically all these in mind when you interpret the prolactin and the symptoms. Now going to the more interesting part of my talk, the recent concepts about prolactin. So the classical view was prolactin is going to be a hormone which is involved in lactation. But we now have evidence showing that prolactin is involved in the metabolic homeostasis. It is involved in neuroendocrine programming. It is involved even in osmoregulation, thermoregulation in the skin, and it is involved in bone metabolism. So how does it do so many activities? This is linked to the prolactin receptor. So if you look at the prolactin receptor, it has got an extracellular domain, and then there is an intracellular domain which is going to activate many pathways, many programming pathways inside the cell. And that is how it has multiple actions, and prolactin receptors are present in multiple tissues in the body. So if you look at the neuroendocrine function, of course lactation is important, but other than that, prolactin is also involved in the maternal nursing behavior. So if you look at the prolactin receptors, they are present in the medial preoptic area. So this area, if you knock off the prolactin receptors here, and they've looked, and most of the data here is from actually mouse models. Most of them have not been substantiated in human beings yet, but these are all concepts which are evolving. So if you look at this, if you knock out the receptors in the medial preoptic area, what happens is these mouse, actually they abandon their litters one day after birth. They do not have the maternal behavior. And whatever prolactin is going to enter the systemic circulation of the pups from the mother's milk is also going to program the pup's brain for future maternal behavior. So these are all interesting concepts which are being studied now. And stress response, again, we know that prolactin is also one of the stress stress hormones. On the other hand, we also have prolactin acting on the bone. So we have prolactin receptors which can stimulate the osteoblasts, and it can regulate the bone resorption via the rank ligand and the OPG system. And especially we see this activation during the lactation, when you have more of bone resorption, a loss in the bone mineral density. And we also have prolactin acting through the sex steroid deficiency, hypogonadism, which can cause low BMD. And this is again more of a sex steroid deficiency which is driving the low BMD in patients with hyperprolactinemia. Again, there are animal models showing that prolactin is also involved in osmoregulation. It is present in the sweat glands, it is present in the hair follicles, and it is used for heat regulation. These are all, again, animal models, not yet substantiated in humans. So we have the autocrine feedback of prolactin. So prolactin is a hormone which is going to inhibit its own secretion. And how does it do it? There is something called as the tubuloinfundibular dopaminergic neurons. They are called the TIDA neurons. So those neurons are the ones which are going to secrete dopamine. So prolactin is going to act on these TIDA neurons. So an increase in the prolactin will go on act on the TIDA neurons, and it will suppress the, or it will activate the dopamine formation there. So the dopamine in return is going to suppress the prolactin secretion from the lactotroph. So it has its own negative feedback mechanisms, and when this feedback mechanism is impaired, you may develop prolactinomas, you may develop lactotroph tumors. And now studies are being done to see if there could be some modulation of this pathway which could be done as a form of treatment for resistant prolactinomas. And Sriram sir already spoke about kisspeptin. So again, hyperprolactinemia is also going to cause hypogonadism. And how does it cause hypogonadism? We know that it is going to suppress the GnRH, but how does it do it? There are something called as a candy neurons. So candy neurons, one of this is the kisspeptin neuron, which is going to secrete kisspeptin, and the kisspeptin acts on the GnRH, and the GnRH neurons later secrete LH and FSH. So this is the normal pathway. So what happens in hyperprolactinemia? The increased prolactin is going to suppress the kisspeptin neurons. So the downstream pathway, that is the kisspeptin going and stimulating the GnRH, does not happen. And there is a reduction in the LH and FSH, and this leads to hypogonadism. So this is a main mechanism of how it causes hypogonadism. And so the receptors are present even in the candy neurons. So there can be a little bit of a diagnostic nuance when you look at the FSH and LH values. In patients with microprolactinomas, it is more of a neurohormonal effect. So you will see a slight elevation in the FSH and a reduction in the LH. On the other hand, when you have a macroprolactinoma, which is causing a mass effect on the GnRH neurons, you will have both the FSH and LH, which is suppressed, which will give you a clue. When you look at the LH and FSH values, it will give you a clue whether this is a microprolactinoma or a macroprolactinoma. And then there is something called as a menopause paradox. So what happens here again, the kisspeptin neurons, they secrete the neurokinin B, which is involved in hot flashes. So if you treat a patient in menopause with this cabergoline, so you're going to reduce the prolactin values. And what does a prolactin do? The prolactin is going to actually go and suppress the kisspeptin neurons. So then there can be a slight increase in the neurokinin B, and that can somehow bring out the hot flashes in people who are treated with this cabergoline in patients, in menopausal patients with hyperprolactinemia. So beyond reproduction, we have now newer concepts about prolactin being a metabolic hormone. So it has effect on the liver, it has effect on the pancreas, and in the adipose tissue. Now the older model was more focused on the lactation part. Now the newer model is looking at the metabolic pathways of prolactin. So we have prolactin receptors as well as dopamine receptors which are present in the beta cells. Now prolactin is a weird hormone because less prolactin as well as very high prolactin, both are going to cause metabolic abnormalities. So prolactin as such, it is going to increase the beta cell activity, it is going to increase the beta cell proliferation. But when you have very high prolactin values, there is dysregulation and there can be a sort of insulin resistance, a burnout of the beta cells. On the other hand, dopamine receptors are actually found to have a beneficial effect on the beta cell activity. So there is an increase in the insulin secretion, and that is also one of the reasons why bromocriptine is approved as one of the anti-diabetic drugs. And when it comes to human adipocytes, we have prolactin receptors as well as the dopamine receptors. Prolactin receptors, still the concept is not very clear whether it leads to lipogenesis or lipolysis. On the other hand, stimulation of the dopamine receptors in fact is beneficial for the adipose tissue. So prolactin excess can cause an increase in the or abnormal lipid profile. It can lead to an increase in the LDL, triglycerides, a decrease in the HDL, and there is an abnormality in the body composition as well, increased fat percentage, and there is a reduction in the glucose tolerance, a rise in the fasting insulin, increased OMA-IR, and a decrease in the insulin sensitivity. And if you look at your hyperprolactinemia patients, about 50% may actually have metabolic syndrome. And how does this do this? A chronic prolactin excess in fact goes and gives a functional block of the dopaminergic tone. And this leads to uninhibited hypothalamic orexigenic signal. So you have an increase in the appetite, you have an increase in the neuropeptide Y, you have an increase in the agouti related peptide. All of these are the orexigenic hormones. And then there is an increase in the appetite which lead to hyperphagia, and it can lead to obesity. And there are also some gender nuances. It's not the same for both men and women. There are certain gender differences which are seen. So there is a significant reduction in the apolipoprotein A1 and 2 in those in women with excess prolactin, and a deficiency. So hypoprolactinemia again can lead to a detrimental impact on the glucose metabolism in women. In men, there is more of body composition changes and again an increase in the metabolic syndrome. So in men especially, if you look at it, just treating a hyperprolactinemia with cabergoline will not lead to complete resolution of the metabolic syndrome. There is still a residual risk, especially if it is associated with hypogonadism, and you need to give testosterone. Within 6 months of cabergoline treatment, if the testosterone does not improve, you will have to give testosterone to mitigate the metabolic effects of hyperprolactinemia. It is not only hyperprolactinemia which is dangerous, it is also hypoprolactinemia. So a low prolactin, less than 7, there are multiple studies showing different cutoffs, but less than 7 is generally taken a cutoff where it is associated with more metabolic abnormalities. So especially when we are treating patients with prolactinoma, we should not be over enthusiastic in bringing down the prolactin levels to very less values, because that itself can be dangerous and that itself can lead to an increase in the metabolic syndrome. And hypoprolactinemia is also associated with MASLD, because prolactin, it maintains a normal CD36 expression in the liver. So what does the CD36 do? It is like a gate. So it is going to open up for increased flux of the fatty acids into the liver. So when you have a reduction in the prolactin value, the CD36 gets upregulated. So the gate opens and then there is going to be more fat influx into the liver. So this is the typical U-shaped metabolic risk curve with prolactin. Too less, too much is dangerous, and we need to reach the homeostatic sweet spot. And this is again a newer term. It's called homeostatic functionally increased transient prolactinemia. So any value between 25 to 100 is considered to be a physiological adaptation, because values slightly higher, about 40, is found to have an increase or a better metabolic stress or metabolic adaptation to stress in human beings. So this is a newer concept. They say 25 to 100 is relatively okay. So to conclude, prolactin is far more than just the galactorrhea hormone, and a key clinical step is accurate clinical diagnosis. Always correlate the clinical condition with the lab values, and then look for other artifacts and nuances in the lab artifacts as well. And it has myriad clinical presentation. It's not only galactorrhea. And now metabolism is a new prolactin story. And prolactin modulation, could it be a true metabolic therapy in metabolic syndrome, where we are playing around with all the receptors, the GLP-1, the GIP, the amylin receptors, the cannabinoid receptors. So could prolactin receptors also be one of the modalities or one of the targets of treatment for metabolic syndrome? The future research has to tell us. So thank you for patient listening.